Great. It's a pleasure to introduce Dr. Anjali Jain, who is a general pediatrician and vice president at the Lewin Group. Lewin Group is a health and human services research and policy group in Falls Church, Virginia. And I think rather than taking any more of your time, Anjali, welcome, and we'll turn this over to you.
Good morning. Thank you for inviting me to speak here. I wanted to note that we had a huge discussion about what to call these conditions and ultimately settled on co-occurring conditions. So that's one possibility. So I've discussed our study before, and I could certainly spend the entire time talking about the study overall. So I'm going to assume that you'll ask questions if you need to, and I'll just give a very brief overview of what we affectionately call the health outcome study. So it consists of 4 tasks. Most of what I'm going to be presenting today is really from the first 2 tasks. The task A is really to just look at the data. This is a large health insurance claims database or administrative database. And the first part was to identify children with autism as well as their family members and also identify a control group or a comparison group of children and their family members. And then part of that, of course, was to validate their ASD diagnoses using a chart study. In task B, we compared overall very just descriptively the health outcomes of children with ASD and without ASD, as well as that of their family members. And task C and D looked more at utilization patterns as well as etiologic risk factors, which I won't be discussing here today. So this is the Optum Insight Research Claims Database. The group involved was us at Lewin and Optum, which is our parent company now, as well as Craig Newshafer and his colleagues at Drexel University, who was the main core of the team. So we had medical and pharmacy claims and linked enrollment information from 1993 to present. For this particular, the results I'm presenting today, the results are from 2001 to 2010. The database itself is geographically diverse across the U.S. It's fairly representative. So it has a little more in the Northeast and the South compared to the West, for instance. And it also is linked to a sociodemographic marketing database. So we are able to get person and household level data on socioeconomic characteristics as well as a match for some of the other basic sociodemographic characteristics for the population. This just gives you a sense of the numbers, which are start out very large and get smaller pretty quickly, but still end up quite sizable. So the database overall during this time period has about 62 million individuals. This is adults and children. And if once you require them to have about 6 months of coverage or more, that number cuts down to about half or 30 million. It's 9.5 million or so of those are kids, meaning they're in the database from age 0 to age 20 at the beginning of their follow-up period. We were not explicitly not studying Rett syndrome and CDD, so we took out the children who had any of those diagnoses. And we ended up with about 46,000 children who had evidence of ASD. And what I mean by evidence is that they had at least one claim with an ICD-9 code for one of the Asperger's, autism, or PDD-NOS codes. We also polled their siblings and parents, and as well as a 3-to-1 comparison group and their siblings and parents. And because they're on the same health plan, we were able to do that and get some family level characteristics. I will be presenting a little bit of that data very briefly. Based on the chart validation, we decided for most of our multivariable analysis and more detailed analysis that we were going to stick to children who had a more definite diagnosis of ASD, and those are the kids that had at least 2 claims with an ICD-9 code that fell into the appropriate categories. And so those kids we're calling likely autism versus the others are probable or possible autism. So you'll just see that terminology used in the next few slides. So to look at comorbidities or co-occurring conditions, the first thing we did is we used the ARC clinical classification software, which basically breaks down groups of ICD-9 codes into various categories. And in general, this slide, I'm not going to get into it in detail, but basically shows what we'll continue to show is that children with autism, either likely or possible, had greater rates of almost every group of conditions compared to the comparison group. Some of the codes that fall into these various categories are not very intuitive, and so we did look at groups of codes separately, as well as developed our own sort of working model for a clinical comorbidity index to use in children, and I'll present those results shortly. So looking first at some of the mental and behavioral health comorbidities. So as you can see here, oops, okay, I'll get this. So the likely group, again, this is two claims, so they're sort of more definitely have an autism spectrum disorder. Possible group are the ones with only one claim. Probable are the group altogether, or total ASD, and here's the comparison group. So, as you can see, the numbers are large. And if you just compare total to comparison, you can see that the prevalence in the data set of anxiety, attention deficit, bipolar, all of these disorders are much higher prevalence than in the comparison group. I don't think that there's any huge surprises here. One thing you might note is that the rate of intellectual disability is quite low compared to what we think it probably is, and I think that's a function of these being medical claims, and so intellectual disability is just not well coded, so we don't expect that to be a very reliable estimate. So this is, we were searching for an appropriate index of clinical comorbidity in children and actually didn't find much. And a lot of that has to do with children not having a lot of necessarily mortality or even morbidity at a very high rate during childhood. So the best thing we found was something called the CCC, or the Clinical Comorbidity Index, that was mostly used for children who had spent a lot of time in the hospital itself. So we decided to modify that and break it down into an ordinal scale for each of these categories. There was an additional category of developmental disorders that we took out because that was the disease of interest, of course. And we looked at the overall comorbidity. This was mostly needed and useful in our study so that we were able to control for some of these other conditions when we were looking at other health outcomes, and as well as utilization. So here we also grouped co-occurring conditions or comorbidities into several different categories, and these have their own set of ICD-9 codes. I do have some handouts that list those codes if anyone is interested, but for these main groups of conditions, we compared children with ASD to comparison groups, and again found much higher rates of infectious diseases, neurological, neurodevelopmental disorders, mental health conditions, metabolic dysfunction, autoimmune disorders, congenital and genetic disorders, and gastrointestinal nutritional disorders. Again, not all of this is surprising or known, but one of the things that I think such a large and heterogeneous data set does for us is it sort of narrows the range of prevalence of these conditions. Because if you looked at the literature previously, you would get something like between 9 and 80% of children have X. So I think this gives us a little bit more of a handle on what the kind of norm is. Something like infectious diseases is not immediately obvious why children with autism would have them in such a greater quantity. So those were some of the maybe under-recognized conditions that we don't quite understand but might give us a handle on what's going on. The comorbidity score was low across the board, but as you can see, it was still much higher in children with autism compared to the comparison group. So this is siblings. So these are all the siblings of the children with ASD compared to the siblings of the comparison group. So the children themselves, as well as the children themselves in the comparison group, were not included in this analysis. So as you can see, the siblings also have higher rates of just about everything. Not close to what the children with autism have, but still considerably higher. And I think that this kind of is provocative in the sense that it starts to give us a sense of what might be biologic, what might be environmental, what might be going on, and are these the same conditions that they're having with their siblings, or are they different conditions? So I think that this data can be explored further, and certainly the ideas can be. And again, their comorbidity score was also higher, but only a little bit higher. We did some more detailed analysis, and this is actually now published as a paper, looking at injuries in children with autism, and we confirmed what's been shown in the literature, basically, is that children with autism have more injuries than children without. However, what we found in our analysis is that a lot of that difference is really explained by co-occurring conditions. So that really makes you think twice about how both intervention as well as the mechanism of the injury. And for any injury experts, injuries in children vary hugely by age group. And so what we did do a more detailed analysis on injuries in children with autism by age group compared to those without. And indeed found that injuries are much higher in the younger kids compared to the other children without autism, but they're actually much lower in teenagers. And a lot of that is explained by fewer motor vehicle accidents. So one of the things that was really perplexing about how to adequately control is this issue of surveillance bias. So children with a chronic condition like autism are getting more health care. And sure enough, in our data set, on average, the children with autism had longer continuous enrollment periods. So their enrollment period on average was about 3 years in the data, whereas the comparison group was about 2 years. And so one of the problems with any study of co-occurring or comorbid conditions, I think, is trying to understand the extent to which things are being picked up versus occurring. And so one of the things we did is we just, this is a very crude marker, but we used preventive visits as a marker of healthcare users and found that at least for the chronic conditions, it didn't change the results significantly. However, when we looked at things like otitis media and pneumonia, surveillance bias seemed to play a huge role in terms of how often they're picked up. So I think in any sort of further research of co-occurring conditions, we need to pay really close attention to this issue and the extent to which we're diagnosing things versus they're actually occurring at increased rates. And this is just some of the geographic differences that I wanted to have available in case anyone has questions. But here you can see that the enrollment times, for instance, vary quite a bit. And then just a couple questions. One of the things that I think such a large and heterogeneous descriptive database does is it allows us to potentially observe what's going on in terms of the occurrence of comorbid conditions, as well as potentially use some of the newer data mining techniques to try to get a sense of the degree to which there might be clinically meaningful subgroups of children where conditions are clustering together, and that might help us to understand both autism itself and its manifestations, but also particularly how to intervene appropriately in different groups of children. And then I already brought up the extent to which some of the patterns of comorbid conditions in families might be helpful for us to understand both etiology and the ability to intervene. How am I doing on time, okay?
Yeah, we've got a minute or two left, but
Okay. Thank you.
Okay, all set. Thank you.